You know, it's interesting. We're talking about today being World Diabetes Day, and I wonder if these two have anything to do with each other. We received a press release just the other day, and I took a look at this and thought, wow, we need to talk about this because I would never have believed the kind of numbers in terms of cost that obesity in this country is actually now costing Canadians. So it's from an organization called Obesity Canada. Dr. Alexandro Zarruk is an internal medicine specialist focusing on cardiometabolic medicine and is on the line. So, Doctor, first of all, thank you for being here. And let me ask, with respect to these numbers that I'm seeing, the first kind of line says it all, which says, a new report by Obesity Canada highlights that in 2023, now this is the cost, and that's an interesting word, the cost of inaction in treating obesity across the country reached over $27 billion. That's 20% higher than even previously estimated. So let's begin with that. When we say about the cost of inaction, what are we talking about specifically?
Yeah, so firstly, thank you for inviting me. Secondly, 27B, right? $27 billion. And you can actually split cost in two subcategories. Number one, direct cost. Direct cost is basically numbers of extra visits at the doctors, extra visits at the emergency room, maybe extended length of stay at the hospital because we live in a larger body with obesity. And then you have indirect costs. And indirect costs is also quite surprising. We're talking about $21 billion when we talk about indirect costs. We're talking about lack of productivity at work. We're talking about days that we have to call off because of short-term or even long-term disability, for that matter.
By the way, you know, when you talk about those sort of indirect costs, right, and one of the things in the report suggests that, for example, in the case of women, who would have guessed this, women with obesity actually earn less than healthy weight women, and this is perhaps even more stunning, 5.3% less likely to be employed in the first place. It notes that men do not face the same challenge. So, you know, you look at something like that and you realize how unfair that is. But at the same time, from what I understand, both federal and provincial governments don't acknowledge obesity as a chronic disease.
So that's absolutely correct in regards to the sexism and the genderism that we actually saw in this report. There is around 4% women that, or 4%, general median income compared to 0% or 0.3% less income for men. And there's also 5% more women that are having problems finding a job or being recruited for a job, completely unacceptable. And when we talk about accepting the diagnosis of obesity as a chronic disease and not as a risk factor, which was the case for about 30 years, and considering it for what it is, a chronic, progressive, relapsing disease, we have a problem because we're missing out. Society is missing out on a lot of taxes because there's a lot of people not being employed, and there's less revenue also from the people that are employed.
You know, and I'm sure some people listening as you say that, this idea of obesity is a chronic disease, sitting and shaking their head saying, wait a sec, okay, yes, nobody wants to necessarily be obese, but it shouldn't be considered a chronic disease. Why should it?
Yeah, that's a good point. So when we talk about chronic disease diagnosis, we have to look at three main things. Number one, could it be genetic? Absolutely, it could be genetic. So not only are children sometimes born already with a predisposition because, for example, they have no satiety. Imagine that, or complete compulsion to eating. So that there is a genetic component. Number two, we have to have a state where we have repercussions on life expectancy. Well, it goes without saying, we know that obesity, as soon as we're touching the BMI of 35 to 40, we're talking about 10% decrease in the chances of reaching the normal age of 70, right? And when we talk about BMI above 40, we're talking about a reduction of about 20 to 25% of chances of reaching the age of only 70. Mm-hmm. And the third one is when a state, or disease state for that matter, actually causes a inappropriate functioning of either an organ or the whole body itself. And we know that obesity can actually cause osteoarthritis, musculoskeletal pain, lower back pain. It's associated with headaches. It's associated with migraines. It's associated with infertility in men and women. And then we can go into diabetes. Today is a special day. It's Diabetes Day, right? So we know that obesity and dysfunctional or excessive adipose tissue can be associated with increased risk of developing type 2 diabetes. So we answer the three. We answer the three criteria.
The question I would ask is, given that, and given that you have all these figures, and these are, based on science, based on actual, people and statistics, why have governments not gone ahead and say, yes, we recognize this, we recognize the cost to all Canadians on this, and done something about it? Because it would seem to me, we spent some time last week here on this show talking about whether governments here provincially should cover the cost of Ozempic, for example, and not have to have people pay out of pocket for it, because we know it's good, and if you're obese, it will help you. Is that part of the discussion here?
So I think a lot of people nodded their heads when we were talking about chronicity and chronic disease and obesity. But a lot of organization, for example, here in Quebec is INES, the Institut National d'Excellence en Santé et Services Sociaux. They were saying in 2022 that they do recognize that maybe pharmacotherapy should be recognized. But now that we have data on the cost of inactivity, of inaction, now that we have that data, maybe we're going to be able to nudge the needle in the right direction to at least allow pharmacotherapy access to people that need pharmacotherapy. But we have to understand that it is far more complex than just pharmacotherapy when we talk about living with a disease that is, we know, relapsing. Because the moment that we stop doing this action, in some people, it will come back, and it comes back with a vengeance.
So if that's the case, as you say, if pharmacotherapy is not necessarily the solution for everyone, how do you put people on the right track here? What should people, who want to be able to do something about this do?
Well, I think in Obesity Canada, we actually believe that it has to be a complete, holistic approach. So which means that we should have access. Everybody should have access to this multidisciplinary approach, right? Not only the people that have private insurance should have access to a nutritionist or a kinesiologist. Everybody that lives with a obesity, maybe an obesity with complication, a little bit more advanced, but at least we should have access to nutritionists. We should have access to kinesiologists. We should have access to pharmacotherapy if we can. In regards to bariatric surgery, a lot of people have access to it, but in some provinces, we're talking about 8 years of wait time.
Right.
And a lot of things can happen in 8 years.
So, again, people listening to...
It has to be holistic, Aaron.
As you say it, though, I think to myself, to make all those services available to people, which obviously would be the right way to go ahead and do this, right? Because every little bit helps, whether you're seeing a pharmacist, whether you're seeing a kinesiologist, whatever it takes to get you to the state where you no longer have to be dealing with obesity, or you're treating it and seeing results. Do you have a dollar figure attached to that? Because it would seem to me, there aren't enough people doing this. As you just mentioned, you have to wait for appointments, certainly for months, sometimes for years. How do we even begin to solve that problem?
That's a very good question. And I think that we're not even getting close to that $27 billion price tag of inactivity. Even when we talk about giving access, because we understand this, not everybody's going to jump on board in following a nutritionist. Not everybody's going to jump on board on following a kinesiologist, pharmacotherapy, or even the option of going for bariatric surgery. But it doesn't even come close to the figure of $27 billion. Now, this being said, I think it's the option, the available option of going that route that we are lacking, right? A lot of people, for example, get a prescription for pharmacotherapy. You were mentioning semaglutide 2 seconds ago. And they get to the counter, the pharmacy counter, and they get kind of negated on the fact that it's not covered for them,
right.
And they actually feel like, I'm not worthy for this. I'm not sick enough. Imagine I've got people coming to me celebrating the fact that they're not now diabetic, because now they're going to be able to have access to some pharmacotherapy that will help their obesity.
We have a
It's
long,
very
clearly,
bad.
yeah, as you're laying it out, we clearly have a long way to go here. Obviously, governments will be paying attention to this study by Obesity Canada and start to hope that we can at least start to make some changes here because, as you said off the top, the numbers, for certainly in cost, are staggering, and the number of people suffering is beginning to get bigger and bigger as well. And that's something I think we can say that all of us want to be able to say we can do something to help. So keep fingers crossed. I thank you so much for your time this afternoon. Very much appreciate it.
Thank you, Aaron.
All right. So again, if you want to check it out, Obesity Canada, it is an organization. All this data is there on this new study that they've released. And as I said, it's quite something to see the numbers involved in here and the numbers of people who we now say are in fact obese. That number keeps going up and up and up, even in Canada.